Welcome to the deep dive. Today, we're really getting into the weeds on a critical topic for specialist clinicians, late radiation injuries and the role hyperbaric oxygen therapy plays.
Exactly. We've got a comprehensive source text here, and our aim is to unpack it thoroughly, going beyond just a summary to really explore the details, the etiology, the evidence, the controversies.
Right. For those of you dealing with these challenging cases, getting straight to the core knowledge is vital. We'll be exploring why these injuries happen, how hyperbaric oxygen, or HbO2, actually works at a biological level, and what the evidence really says site by site.
Delayed radiation injuries, or LRTI as the source often calls them, are a major burden for cancer survivors. They can seriously impact quality of life. So understanding the latest thinking and management strategies is essential. This deep dive aims to give you that full picture, straight from the source material.
Okay, so here's the plan. We'll start with the basics. Defining LRTI, differentiating it from acute and subacute effects. Then we'll delve into the complex biology, the why.
Then the main part of our discussion will be a detailed look at HbO2, site by site. We're talking mandible, bladder, bowel, skin, even the central nervous system, looking closely at the evidence presented for each.
We'll also hit some special considerations like using HbO2 preventatively before surgery in radiated areas. That's a really interesting angle.
Absolutely. And we'll tackle that common question head on. Does HbO2 affect cancer growth? We'll view the data and the source on that. And finally, we'll touch on utilization, cost impact, practical things.
So it's a thorough exploration designed to give you the detailed insights you need for these complex clinical situations. Let's dive in.
Delayed radiation injuries, soft tissue and bony necrosis, and potential for future research introduction.
All right, kicking off with Chapter 8 of our source material. The focus right away is hyperbaric oxygen, HbO2, for treating and preventing late radiation tissue injury, LRTI.
Yes, that's the core. But the introduction also signals that we'll touch on related areas too, like potential research directions and, crucially, the safety profile of HbO2 for patients with a history of cancer.
It's really quite striking just how common this indication is. The source states delayed radiation injuries are the most frequent reason for hyperbaric treatments in the U.S. About 40% of all hyperbaric billings. That's huge.
It is, and a critical point made right at the start, and this is something you really need to grasp, is that HbO2 is almost never a standalone treatment.
Right.
Especially if bone necrosis is involved, managing LRTI effectively requires a team effort. A multidisciplinary approach is usually essential.
So you need different specialists working together, optimizing every aspect of care. That includes the surgical techniques, which are often vital.
Definitely. Surgery might involve tissue flaps, skin grafts, basically reconstructing areas damaged by the radiation or previous cancer surgery.
And the source mentions advances like microsurgical free flaps, these complex procedures connecting tiny blood vessels. They're apparently making these reconstructions more successful, even in tough, previously radiated tissue beds.
That's right. But even with those sophisticated surgical options, the source describes HbO2 as still offering significant benefit. It's an important adjunct therapy.
So the intro really sets the scene. We're going to explore the etiology, why these injuries happen, the mechanisms how HbO2 helps. We'll look at clinical results, both the positive findings and studies with, let's say, less convincing outcomes, including critiques of their methods.
And importantly, the effects, or lack thereof, of HbO2 on cancer growth, potential research areas, and the cost implications. It's a full spectrum look.
Okay, so just to quickly frame this initial section, we're diving deep into HbO2 for late radiation injury, or LRTI. It's a major indication, driving a lot of hyperbaric center activity, but it's typically part of a larger multidisciplinary plan, often involving surgery. We're set to dissect the what, why, and how based strictly on the source's evidence. Technical advancements in radiation delivery.
Okay, next, the source brings up the significant changes in how radiation therapy itself is delivered over the past, say, 20 years.
Ah, yes, the modern techniques. Things like intensity-modulated radiation treatment, IMRT stereotactic radiosurgery, hypofractionated stereotactic approaches. It's all about precision now, isn't it?
Exactly. These methods rely on, well, incredibly precise imaging to locate the target and equally precise delivery systems. They often use lots of tiny beams, sometimes 100 or more, shaping the dose very tightly.
The goal being to conform the radiation to the tumor volume while optimally protecting the surrounding critical normal anatomy.
And these complex targeted techniques have become pretty standard for many curative treatments. Head and neck, breast, lung, thoracic, abdominal, pelvic cancers. It's widespread.
So with this improved targeting, the expectation was naturally fewer late radiation injuries, right?
That was the hope, yes. Many in the radiation oncology community predicted fewer LRTI episodes. But the source presents a more nuanced picture.
How so?
Well, because these techniques allow for higher radiation doses to the tumor, which is good for cancer control.
Mhm.
The actual incidence of late complications like LRTI has often ended up being, well, comparable to older methods.
So the improved tumor control, which is obviously a major benefit, comes with a trade-off, potentially. The higher dose might counteract some of the tissue sparing.
It seems that way in some cases. The source explicitly states that tumor control is improved due to the higher doses. However, it also says it's not yet firmly established that IMRT, for instance, delivers a lower incidence of osteoradionecrosis, or ORN, and other serious late complications across all sites.
Interesting. The source mentions some differing views, too. Dr. Robert Marks, who pioneered HBO2 for mandibular ORN, apparently feels he's seen a higher incidence of ORN since IMRT became standard for head and neck cases.
Right. But conversely, there are reports suggesting a lower incidence of radiation proctitis when IMRT is used for pelvic tumors, and maybe less severe xerostomia or dry mouth when IMRT spares salivary glands in head and neck treatments.
So it's a mixed bag. It seems the impact of these advanced techniques on the overall rate of LEAT injuries is still kind of debated and might depend heavily on the specific site being treated and the doses used.
Precisely. The ability to escalate the tumor dose might be a confounding factor in some areas, potentially negating some of the expected normal tissue benefits.
Okay, quick recap here. Modern radiation like IMRT allows higher doses and better tumor control. The hope was fewer late injuries, but the reality seems mixed. Incidence might be comparable overall, possibly due to dose escalation. Some specific sites might see fewer issues, like proctitis or xerostomia, while others, like the mandible, according to Dr. Marks, might even see more ORN. The overall impact is still under evaluation, the nature of radiation injury.
All right, let's talk about the injuries themselves. The source classifies them based on timing: acute, subacute, or delayed.
Okay, starting with acute injuries, these are the immediate ones, right? Caused by direct cellular impact, damaging DNA in the normal cells around the tumor.
Exactly. It's free radical-mediated DNA damage. Many cells affected suffer what's called mitotic or reproductive death. The DNA damage is severe enough that they can't successfully divide again.
And this is thought to be the main way radiation kills cancer cells.
Primarily, yes. But it also hits normal tissues, especially those with rapidly dividing cells. Think of the lining of the GI tract, from the mouth all the way down.
So that explains the mucositis, the mouth sores, the gut issues often seen during treatment.
Precisely. Those are classic acute injuries. The good news is, in normal tissues, these are typically self-limited. They almost invariably resolve within a few weeks after finishing radiation.
Rarely lasting beyond 2 months, the source says. And treatment is mainly symptomatic pain control, nutritional support.
Correct. But it's important not to downplay them. Though self-limited, they can be incredibly debilitating while they last. And the source makes a key point. With the common use of simultaneous chemotherapy and radiation these days, these acute reactions are often much, much more severe than they used to be.
Got it. So acute injuries. Immediate DNA damage hits rapidly dividing cells, gut lining, usually resolves in weeks, but can be severe, especially with chemorads. Symptomatic treatment.
Okay, then we have subacute injuries. These appear a bit later, and typically only in a few organ systems.
Such as
The lung is a good example. Radiation pneumonitis, it presents like bronchitis, usually starting around 8 to 12 weeks after treatment.
okay.
Another site is the spinal cord. Subacute injury there can cause temporary demyelination damage to the nerve sheath. This leads to something called Lermid's sign.
Which is?
It's characterized by electric-like shocks or tingling down the legs when the patient bends their neck forward, caused by that temporary demyelination.
Are these permanent?
Usually not. Like acute effects, subacute injuries are most often self-limited, though they can persist for several months. Very rarely they might evolve into delayed injuries. Treatment is again symptomatic. Steroids are often used, but no specific therapy is particularly effective. Supplemental oxygen might be needed for pneumonitis.
Okay, so subacute. Appear later, 8 to 12 weeks. Fewer systems involved, lung, spinal cord. Usually temporary, but can last months, rarely become delayed. Symptomatic treatment, sometimes steroids or oxygen.
And that brings us to the main event, delayed injuries, or LRTI. These are the ones we typically see after a latent period of 6 months or more, sometimes many months or even years after the radiation exposure.
And during this latent period, the patient has usually recovered from any acute effects and the delayed damage hasn't surfaced yet.
Correct. That symptom-free interval is characteristic. Although, The source notes that in rare, high-risk situations like reirradiation or maybe a genetic predisposition LRTI can sometimes manifest earlier.
And what about those consequential effects mentioned earlier?
Right. That's when severe acute injuries, often from combined chemoradiation, just don't heal properly and transition directly into a chronic injury state that looks just like LRTI. They lack that typical symptom-free latent period.
Can anything trigger these delayed injuries?
Often, yes. An additional tissue insult, like trauma or surgery within the radiated field, can precipitate LRTI. But importantly, they're frequently spontaneous. No immediate trigger can be identified, they just develop.
So, delayed injuries, LRTI. Long latent period, 6+ months typical, but sometimes earlier in high-risk cases. Severe acute effects can become chronic without latency. Consequential effects can be triggered by trauma surgery, but often appear spontaneously.
And just briefly on HBO2 for acute or subacute injuries, the source notes this hasn't been well studied. There's some interest. But since these conditions usually resolve with supportive care anyway, the cost-effectiveness of adding HBO2 would be a major consideration.
Makes sense.
Now, regarding the significance of delayed injuries, it's important to remember that only a fraction of patients, maybe 5 to 10%, develop LRTI serious enough to require medical intervention.
But for that group, it's a major problem. And the source makes a critical point here about treatment alternative.
Yes. Without HBO2, the definitive treatment for severe LRTI, especially with actual tissue death or necrosis, is often surgical removal of the damaged part.
Which, as the source says, is just not acceptable if that part is essential for quality of life or even for life itself, like
Right.
removing someone's entire larynx or bladder.
Exactly. So while not everyone gets severe LRTI, for those who do, HBO2 offers a crucial alternative or adjunct to potentially function-destroying surgery.
And it's not just about frank necrosis, is it? The source emphasizes other consequences, too.
Absolutely. Stenosis narrowing and fibrosis scarring in hollow organs like the bowel, bladder, esophagus, even the trachea despite its cartilage. These are also profound consequences of delayed radiation injury.
And these changes mess with function, right? Making organs stiff, unable to expand or move things along properly.
Precisely. And these injuries from fibrosis and stenosis are just as challenging and resistant to conventional treatment as those where you see obvious tissue death.
And HBO2 is still beneficial here, even without necrosis.
Yes, the authors recommend it. Case reports support its use. Often it's combined with mechanical dilation, sometimes using a Marks-like protocol, maybe 20 HBO2 treatments before dilation, 10 after.
So that's a key takeaway. HBO2 isn't just for visible necrosis. It's indicated for problematic fibrosis and stenosis in organs too, often used alongside procedures like dilation.
The source includes Figure 1, which diagrams the evolution of LRTI. It shows radiation treatment alone kicking off a biochemical cascade. Cytokines like TGF-beta, interleukins, TNF-alpha are released. Then there's a latent period before LRTI evolves.
And the other pathway.
That's when chemo is given with radiation. It shows heightened acute reactions that can worsen and persist, potentially evolving directly into LRTI without that latent period, the consequential effects. Both pathways ultimately lead to the clinical manifestation of delayed injury, described as involving endarteritis, fibrosis, and microvessel depletion.
So Figure 1 gives a visual map. Radiation alone, biochemical cascade I, latent time, LRTI. Chemo plus RADS, C or acute passes potentially direct evolution to LRTI, consequential effects, or standard delayed injury. Both pathways involve those key processes like endarteritis and fibrosis, the etiology of delayed radiation injury. Okay, let's dig deeper into why these delayed injuries happen. The source says it's complex and still only partially understood.
That's right. The radiation oncology community is still studying it. But one thing that's seen in virtually all cases of late radiation damage is vascular change specifically. Obliterative endarteritis. The small arteries become inflamed and blocked.
And because HBO2 is known to promote angiogenesis, the formation of new blood vessels.
Exactly. The traditional thinking in the hyperbaric community has been that enhancing angiogenesis to counteract this vascular damage is the main way HBO2 works for LRTI.
But there's newer thinking now.
Yes. Some radiation scientists are now convinced that, at least for certain organ systems, these vascular changes might play a lesser role. Instead, they emphasize things like radiation-induced apoptosis, programmed cell death, and, critically, abundant tissue fibrosis as the main drivers of delayed injury.
So maybe the block vessels aren't the whole story, or even the main story, in some tissues.
That's the emerging view for some. The source refers back to Figure 1, noting a more complex model is evolving. In the past, radiation oncologists often distinguished between acute and delayed injury mechanisms, thinking they were unrelated.
But now,
Now, researchers appreciate that the process actually starts at the time of radiation. It involves the release of many bioactive substances, prominently including fibrogenic cytokines molecules that promote scar tissue formation.
and this ties into the fibrotrophic effect model.
Precisely. That model emphasizes the consequences of depleting stem cell populations and the subsequent loss of functional parenchymal cells in the irradiated tissue. It also highlights that exuberant fibrosis you see in severely damaged tissue.
Does that model dismiss the vascular changes?
No, not entirely. Vascular damage and stenosis are still recognized as consistent findings. But this group feels endarteritis itself might not be the primary cause of the delayed injury, at least not in all cases. It's part of the picture, but maybe not the main trigger for the whole cascade in this view.
Okay, so the understanding is shifting. While blocked arteries and endarteritis are always seen, newer models like the fibrotrophic one emphasize stem cell loss, parenchymal cell loss, and excessive fibrosis as potentially more primary drivers, starting with signals released during radiation itself.
Now, hypoxia low oxygen is clearly linked to fibrosis. It's been shown that chronically hypoxic tissues develop exuberant fibrosis, mediated by a factor called HIF1, hypoxia-inducible factor 1.
So in radiated tissues, the fibrosis is likely, at least partly, a consequence of the vascular damage causing hypoxia.
Very likely, yes. But it might be a two-way street. It's also plausible that the fibrosis itself contributes to further vascular damage by physically compressing or squeezing out the small vessels.
A real vicious cycle, then.
It seems plausible, and specific cytokines are heavily implicated. A review mentioned in the source focusing on lung injury identifies TGF-beta as the most studied cytokine, but many others are involved too, loads of interleukins. IL-1, 2, 4, 5, 6, 7, 8, 10, 12, 13, 17, TNF-alpha, GM-CSF.
And these are released during radiation, but the damage takes months or years to show up clinically.
Correct. The cascade starts early, but the clinical expression requiring therapy comes much later.
Okay, so hypoxia, likely from vascular damage, drives fibrosis via HIF1. Fibrosis might worsen hypoxia. Specific cytokines, especially TGF-beta, released during radiation, kick off this long damaging process.
Now, many studies on these cytokines have been done in animal models, like radiation pneumonitis models, but the source notes we haven't yet been able to translate these findings into practical clinical tools, either as predictors of who will get severe LRTI or as therapies.
Why not?
Well, partly because it's complex, no single marker seems reliable, plus there's huge individual variation in radiation tolerance based on genetics.
Yeah.
Some patients are just much more sensitive.
If we could predict sensitivity, that would be incredibly useful, wouldn't it?
Absolutely. If we had reliable predictors before or during treatment, we could potentially adjust radiation doses or targeting for those sensitive patients. Maybe even advise some exquisitely sensitive individuals towards alternative therapies, if available.
Or offer prophylactic interventions.
Exactly. Like HBO2, or maybe other drugs, antioxidants, free radical scavengers, anti-inflammatories, ACE inhibitors, growth factors. Things that have shown some promise in mitigating radiation injury. The idea would be to identify the high-risk group and intervene before the chronic injury manifests, preventing it or reducing its severity.
But this all needs rigorous testing.
Oh, definitely. Clinical trials are essential. And the most critical consideration would be ensuring that any attempt to protect normal tissues doesn't inadvertently protect the tumor as well.
Right, that's paramount.
This idea of preventing radiation damage is exactly what led to the Mark's 2010 protocol for dental extractions in heavily irradiated patients, typically 6,000 centigrade.
The goal there is to prevent mandibular necrosis, which can be triggered when you extract a tooth from bone and surrounding soft tissues that are already compromised by radiation, even if the damage isn't obvious beforehand.
Precisely. The trauma of extraction reveals the underlying damage, and some experts argue HBO2's main benefit in this setting is enhancing the status of those supportive soft tissues around the bone.
Got it. Mega recap for etiology. The why of delayed radiation injuries is complex. It starts with bioactive substances released during radiation. The fibrotrophic model points to stem cell loss and fibrosis, alongside the consistently seen vascular damage, endarteritis. Hypoxia drives fibrosis, possibly in a cycle. HBO2 was traditionally thought to work via angiogenesis, but now its role in modulating fibrosis and supporting soft tissues is also considered key. Identifying high-risk patients via biomarkers is a research goal for potential prophylactic strategies, like the established Mark's 2010 protocol for preventing ORN after extractions. The effects of hyperbaric oxygen on irradiated tissues.
Okay, so how exactly does HBO2 help these damaged tissues? The source suggests at least three primary mechanisms are involved.
Right, let's break those down first.
First, HBO2 promotes angiogenesis, new blood vessel growth, and secondarily improves tissue oxygenation.
Makes sense given the vascular damage.
Second, HBO2 appears to reduce fibrosis, the excessive scarring.
Okay. And third,
Third, it increases the mobilization and induction of stem cells, getting these versatile repair cells to the site of the radiation injury.
where they can then differentiate as needed to help repair the organ system. So, angiogenesis oxygenation, fibrosis reduction, and stem cell recruitment.
That's the proposed triad.
Let's look at the evidence for angiogenesis first. Since vascular damage and hypoxia are consistent features of LRTI, boosting blood supply seems like an obvious benefit.
Exactly. And there's solid evidence. An animal study showed HBO2 induces neovascularization in hypoxic rat mandibles after irradiation.
And Dr. Marks has demonstrated this in humans.
Yes, multiple ways.
Yeah.
He's shown it histologically, comparing biopsies before and after HBO2. You see increased vascularity and cellularity. He's also used transcutaneous oxygen measurements, showing a serial improvement in oxygen levels in patients receiving HP2, indicating increased vascular density.
And those improvements lasted.
Remarkably so. He followed some patients for up to 3 years, and the improved oxygen levels persisted without dropping off. Figure 4 in the source actually graphs this, showing the low starting oxygen level in irradiated tissue gradually rising with HBO2 sessions and staying elevated long-term, plateauing near normal levels.
Wow, that's quite compelling visually. Any other evidence?
Yes. Marks also showed increased vascularity in an irradiated rabbit mandible model using angiography comparing HBO2 animals to controls. Another group used Doppler flow studies and transcutaneous O2 measurements in radiated human patients, showing improved blood flow and oxygen content after HBO2. And a case report using microvascular fluorescence angiography in a breast necrosis patient visually documented increased vascularity after HBO2.
So pretty strong evidence from multiple angles. Animal models, human histology, transcutaneous oxygen monitoring showing sustained effects, figure 4, Doppler, angiography, all pointing to HBO2, improving blood supply and oxygenation in irradiated tissues.
Now, what about fibrosis reduction? There's evidence here too, mainly from animal models so far. Feldmeyer and colleagues studied irradiated mouse small bowel.
What did they find?
They showed that giving HBO2 7 weeks after a clinically relevant radiation dose significantly reduced the mechanical effects of fibrosis. The bowel was less stiff and also reduced the amount of fibrotic collagen deposition seen microscopically using special stains like Mason's trichrome.
And figure 2 visually summarizes these proposed mechanisms again.
Yes, it shows those 3 pathways: enhanced angiogenesis, stem cell production mobilization, and reduction of fibrosis-enhanced compliance, all leading towards the goal of resolving or preventing LRTI. It even draws an arrow suggesting angiogenesis might help stimulate stem cell effects.
So animal studies provide evidence for fibrosis reduction, measured by physical properties and collagen staining. Figure 2 provides that schematic overview.
Clinically, there's an interesting observation related to fibrosis. Many head and neck cancer patients develop this really tough, woody fibrosis in the neck tissues after radiation.
Right, I've seen that. It can be quite limiting.
Well, the authors note, and other hyperbaric physicians have observed, a significant softening or reduction in this woody fibrosis after patients undergo a course of HBO2, usually for related mandibular necrosis.
Has this been studied formally?
Not systematically, according to the source. And it's not apparent in every single patient, but is described as a frequent finding. An interesting clinical pearl.
Definitely something to keep an eye out for. So, clinical observation suggests HBO2 might reduce that characteristic post-radiation woody fibrosis in the neck, though it needs formal study.
And the third mechanism, stem cells.
Yes, the work by Dr. Tom's group at UPenn and University of Maryland is key here. They've published studies demonstrating that HBO2 mobilizes stem cells, likely via nitric oxide pathways, getting them into irradiated tissues.
And does this connect back to histological findings?
It seems to. The source notes that Marks's observation of increased cellular density in tissue biopsies after HBO2 following radiation-induced cell depletion could potentially reflect, at least in part, the arrival and activity of these mobilized stem cells. So studies show HBO2 gets stem cells to the damaged area, potentially mediated by nitric oxide, and this fits with observations of increased cell numbers in tissue samples after treatment.
Okay, putting it all together for the mechanisms. HBO2 has been used for LRTI for decades, starting with ORN, also preventatively. The source proposes three main ways it helps: boosting angiogenesis and oxygenation, strong evidence, including sustained effects shown in Figure 4, reducing fibrosis, animal evidence, clinical observations like reduced woody neck fibrosis, and mobilizing stem cells, supported by dedicated studies and histological findings. Because the underlying damage process, LRTI pathophysiology, is similar across tissues, success in one area, like the mandible, provides a rationale for its use in others, like bowel or bladder. This sets us up nicely to look at those specific sites. Hyperbaric oxygen as treatment for expressed mandibular radiation necrosis, ORN.
All right, let's tackle mandibular osteoradionecrosis, or ORN. As you said, one of the earliest and most frequent uses for HBO2 in LRTI dating back to the late 70s.
Yes. Historically, the incidence reported varied quite a bit, depending on radiation techniques and doses, particularly in the pre-IMRT era. Studies reported rates from 0% below 6,000 centigrade up to 9% above 7,000 centigrade. A review estimated 5–10% incidence, depending on the volume of mandible irradiated.
And traditional treatments weren't always successful.
No. One large 30-year review reported only 40% resolution with just antibiotics and surgical removal of dead bone. They identified radiation dose, smoking, and periodontal disease as risk factors.
And dental extractions are a huge factor, really.
Absolutely. In that large review, extractions were felt contributory in 50% of cases. Another systematic review estimated a 7% incidence of ORN associated specifically with tooth extractions in radiated patients. It's the major risk factor.
Interesting that maxillary ORN is rare. Better blood supply.
That's the traditional explanation, yes.
Yeah.
The review mentioning extractions also noted that while prophylactic HBO2 can reduce ORN incidence post-extraction, they felt the supporting evidence was weak at that time. They also mentioned other techniques like antibiotics and careful, minimally traumatic surgery.
Right. Preserving the periosteum, the outer layer of the bone containing blood vessels and bone-forming cells, is crucial for healing and avoiding ORN.
Key points here. ORN incidence varies with dose volume. Extractions are the main trigger. 50% of cases, 7% incidence post-extraction. Maxillary ORN is rare. Traditional treatment success is limited. Risk factors include dose, smoking, dental health. Prophylactic HBO2 and surgical technique are debated but important considerations.
Now, what about the impact of modern radiation, like IMRT? The prediction was fewer ORN cases.
As we discussed earlier, that hasn't consistently happened. Dr. Marks reports potentially more cases, possibly linked to higher doses or concurrent chemo becoming primary treatment. And one retrospective study comparing conventional versus IMRT found no difference in ORN incidence.
So the jury's still out on whether IMRT truly reduces ORN risk compared to older techniques, possibly due to dose escalation strategies.
Clinically, how does ORN present, and when is HBO2 needed? The source says very small amounts of exposed bone, less than 1 centimeter, with normal x-rays might resolve with conservative care, things like irrigation antiseptic rinses.
But if the lesion is larger, or if it's clearly getting worse,
then HBO2 should be started promptly. Sometimes small bits of dead bone, sequestra, might slow off on their own, but for larger areas, formal surgical debridement becomes necessary. If left untreated, larger lesions usually just keep expanding.
and it affects more than just the bone.
Definitely. When ORN develops, it typically involves considerable damage to the surrounding soft tissues as well. Figure 5 in the source shows a classic picture necrotic exposed bone, plus severe radiation-induced dental caries in the remaining teeth. It really highlights the combined bone and soft tissue damage.
Okay, so small ORN lesions, 1 centimeters, might heal conservatively, but larger or progressive ones need prompt HBO2 and likely debridement. It affects bone and surrounding soft tissue, often coexisting with radiation caries, as shown in Figure 5.
Historically, the understanding of ORN was flawed. Early work often considered it a type of bone infection, osteomyelitis.
So early treatment approaches reflected that.
Yes. At places like the USA Hyperbaric Center in the mid-70s, patients got HBO2, often with antibiotics, but typically without aggressive surgical removal of the dead bone.
And the results.
Temporary improvement like pain relief was common, but durable cures were not achieved. It wasn't until Dr. Robert Marks elucidated the fundamental principles that a rational approach emerged.
What were his key findings?
Crucially, he demonstrated that infection is secondary, not the primary cause. Deep bone cultures were often negative for bacteria. He identified ORN as fundamentally a hypovascular hypoxic necrosis tissue death due to lack of blood supply and oxygen.
That's a paradigm shift, and it changes the role of HBO2.
Absolutely. Since a major goal of HBO2 is to improve the vascular environment before surgical intervention, Marks emphasized giving the bulk of HBO2 treatments prior to any surgery, including extractions,
Why before?
to enhance the health and resilience of the surrounding normal soft tissues, preparing them to handle the stress and increased metabolic demand of surgical wounding. He also showed that for HBO2 to be consistently successful, it must be combined with optimal surgery to remove the dead tissue.
And surgical techniques have evolved since then.
Yes, microvascular free flaps, titanium trays, growth factors like platelet-derived growth factor. But the source emphasizes that in Marks's experience, the importance of adjunctive HBO2 hasn't changed. It's still essential.
So the key shift was understanding ORN as hypovascular hypoxic, not primarily infectious. This led to Marks's principles. Pre-surgical HBO2 is vital to improve tissue quality before wounding, and HBO2 must be combined with surgery for durable success.
To guide this combined treatment, Dr. Marks developed a staging system. It classifies the severity of ORN stage 1, 2, or 3.
And it's not just descriptive, it actually directs the treatment plan.
Exactly. The stage dictates the therapeutic intervention. While other staging systems exist, the source notes none have shown clear superiority to the Marks system.
Okay, let's break down the Marks stages and treatments based on the source. Stage 1.
Marks stage 1 ORN is for patients with persistent or rapidly progressive exposed bone, but without the severe signs found in stage 3. Maybe they've had exposed bone for months or it's worsening quickly. Treatment starts with 30 HBO2 sessions before any surgery.
Then surgery.
Then a relatively minor bony debridement, aiming to remove all necrotic bone possible. If the response is good, they get an additional 10 post-operative HBO2 treatments total. 40 HBO2 treatments for responders, 30 pre, 10 post.
Okay, what if that's not enough or more surgery is needed? Stage 2.
Marks stage 2 ORN. This applies if patients aren't progressing well after 30 treatments or if a more major debridement is required. They undergo a more radical surgical debridement or resection in the operating room, often an unblocked resection of the alveolar ridge, the tooth-bearing part of the jaw. Critically, this surgery must maintain mandibular continuity.
And the HBO2.
After this stage 2 surgery, they receive 10 post-operative HBO2 treatments. Since they already had 30 pre-op in stage 1 before progressing, the total is still 40 treatments, 30 pre-surgery, 10 post. The goal remains removal of all necrotic bone while keeping the jaw intact. If continuity cannot be maintained, they advance to stage 3.
Which brings us to stage 3. Who falls into this category?
Marks stage 3 ORN. This includes patients failing stage 1 or 2, or those presenting initially with grave signs like a pathologic fracture, an orcutaneous fistula, hole from mouth to skin, or X-ray evidence of bone destruction extending all the way to the inferior border of the mandible.
So pretty severe cases. What's the treatment plan?
For stage 3, mandibular segmental resection, removing a full thickness piece of the jaw, is planned from the outset, leading to mandibular discontinuity. They receive 30 HBO2 treatments before the resection, followed by 10 post-resection HBO2 treatments, total 40.
And then reconstruction.
Yes, reconstruction is usually done after about 3 months. This might require soft tissue enhancement like free flaps or rotational flaps to support the reconstruction and achieve the best cosmetic and functional outcome. Marks's goal, again, is debridement of ideally all necrotic bone first.
Tell me about the evolution of his reconstruction technique.
In recent years, Marks places a titanium tray at the time of the mandibular resection. This acts as an internal fixator initially. Then, in a second surgery about 3 months later, he fills this tray with autologous bone graft material to recreate the mandible.
What kind of bone graft?
He currently uses cancellous bone aspirated from the patient's ilium, hip bone, mixed with adjuvants like growth factors, bone morphogenic protein, and platelet-rich plasma, and packs this cocktail into the tray within the mandibular defect. Originally, he used freeze-dried cadaver bone trays filled with autologous bone chips.
And importantly, with this evolved protocol using the tray placed at the first surgery, he finds no additional HBO2 is needed to support the second reconstructive surgery. Why?
Because he's shown that the angiogenesis stimulated by the initial 40 HBO2 treatments is stable and persists for at least 3 years. The tissue bed is already optimized.
What about free flaps, which are common now?
Yes, the source mentions that microvascular free flaps, often using bone from the fibula or radius connected to recipient vessels, are frequently used today by many surgeons for mandibular reconstruction. This is a different approach to Marks's staged reconstruction with the tray and particulate graft. Figure 6 visually captures stage 3, showing a pathologic fracture necessitating resection, and then a reconstructed mandible using one of these titanium trays.
Okay, that's a very detailed breakdown. So, stage 1, minor debridement, 40 HBO2. Stage 2, Bigger surgery maintaining continuity, 40 HbO2. Stage 3, segmental resection, 40 HbO2, followed by reconstruction. Marks uses titanium tray plus autologous graft. Others use free flaps. Marks's evolved protocol doesn't need extra HbO2 for the reconstruction step due to durable angiogenesis. Figure 6 shows the severity and hardware involved in stage 3.
And the results with this approach. Dr. Marks recently updated his results on 914 ORN patients treated following his protocols. He reports a 100% successful resolution rate in his hands.
That's remarkable, though you mentioned many required stage 3 treatment.
Yes, about 3/4 of his patients needed the full stage 3 approach with segmental resection and reconstruction. He strongly emphasizes achieving both cosmetic and functional rehabilitation, including the ability to wear a denture or have dental implants placed. These are crucial for quality of life.
He has specific criteria for success in stage 3, doesn't he?
Yes, 6 key points for a successful mandibular reconstruction. 1. Restoration of jaw continuity. 2. Restoration of alveolar height. 3. Restoration of alveolar width, suitable for implants. 4. Restoration of arch form. 5. Maintenance of bone over time. 6. Restoration of facial contours.
So 100% success reported by Marks in 914 patients using his protocols, though many needed stage 3. Success is defined comprehensively by functional and cosmetic outcomes, including implant readiness, review of evidence for HbO2 and mandibular necrosis.
Okay, let's look at the broader evidence base beyond Marx's reports. A 2002 review by Feldmeyer and Hampson found mostly case series supporting HbO2 for ORN. There was one positive randomized controlled trial by Toby et al., but it was very small, 12 patients, and details were unclear, though reported as positive.
Were there any negative studies in that review?
Only one, by Mayer et al. But that study was heavily criticized because they only added HbO2 after the definitive surgery, which goes against Marx's core principle of pre-surgical tissue preparation.
So early review, mostly positive case series, one small positive RCT, one negative study criticized for improper timing of HbO2.
Since that 2002 review, more papers have emerged. A study by Freiberger and Hampson from Duke reported a high durable response rate, 88% resolution response, with long follow-up in a complex group of 57 patients, many of whom had failed previous ORN treatment or even had recurrent cancer.
That sounds promising, but wasn't there a controversial negative trial?
Yes, the Anand et al. Multi-institutional randomized controlled trial. It reported negative results for HbO2 in Mark's stage 1 ORN and caused quite a stir.
Why the controversy? What were the criticisms?
Several serious flaws were pointed out. Most importantly, the study design failed to adhere to Marx's guidance. It didn't integrate HbO2 into a multidisciplinary approach that included surgery. Their apparent goal was to see if HbO2 alone could cure early ORN, which Marx had shown decades earlier wasn't likely without removing the dead bone.
So the negative result wasn't surprising given that design.
Not really, no. Other criticisms included many patients in the HbO2 group received potentially insufficient treatment. Nearly 2/3 got fewer than 22 sessions. The control group's sham treatment, breathing in nitrogen-oxygen mix at pressure, actually carried a risk of decompression sickness. The study was underpowered. There was likely selection bias, as physicians were reluctant to enroll more advanced cases who might get randomized to the non-HbO2 arm, and the primary outcome was assessed at only 1 year, which might be too early, as Marx had shown recurrences can happen 1 to 2 years later, even after apparent resolution.
Okay, so the Anand RCT, while randomized, had significant methodological issues that call its negative findings into question, particularly its deviation from the standard combined HbO2 plus surgery approach.
Another paper by Gallen and Associates looked at 30 patients with Marx stage 3 ORN treated with debrided metrosection and free flap reconstruction. 21 of these patients had previously received some HbO2, details unspecified, without resolution.
What did they find comparing those with prior HbO2 to those without?
The group without prior HbO2 had a 22% complication rate after the free flap surgery. The group with prior HbO2 had a much higher complication rate of 52%.
But this wasn't randomized.
No. And even the authors acknowledged the prior HbO2 group might simply represent more severe refractory cases to begin with. Also, their approach didn't follow Marx's principles of emphasizing pre-surgical HbO2.
So higher complications in a prior HbO2 group in this non-randomized study, but potentially due to treating more difficult cases and using a different treatment sequence than the Marx protocol.
Then there's a 2017 publication by Delman et al. They reviewed their experience, 27 ORN cases out of 509 radiated patients and made recommendations.
What do they recommend?
They supported HBO2 for stage 1 and 2 ORN, but for stage 3, they recommended primary surgical intervention, segmental resection, and free flap reconstruction without routine HBO2, reserving HBO2 only for complex stage 3 cases with extensive soft tissue damage or other unspecified complications.
That seems counterintuitive. Using HBO2 for less severe stages, but recommending complex surgery without HBO2 for the most severe stage.
Exactly. It contrasts sharply with the MARC Stage 3 protocol, which does include HBO2 as a crucial component before and after resection.
So a 2017 paper recommended a different approach for stage 3, favoring free flaps without routine HBO2, contrary to the established MARC's protocol.
And this idea of free flaps without HBO2 for stage 3 ORN has been echoed in a series of papers from several centers since about 2008.
What kind of results did they report?
They report success in reestablishing mandibular continuity in about 85% of cases, which sounds okay. However, they also report serious complication rates around 50%, and in one paper, reoperation was needed in approximately 60% of patients.
That's very high. What about functional outcomes like dental implants?
When reported, dental rehabilitation with implants was only achieved in around 7 to 10% of patients in these series. Plus, these free flap procedures typically require ICU stays, longer hospitalizations, a week or more, and are very expensive, $90,000 or more just for the procedure itself.
And the source suggests this doesn't save money compared to the MARC's protocol with HBO2.
Correct. The source explicitly states this approach does not achieve a financial advantage over the MARC's protocol that includes HBO2.
Okay, so the free flap without HBO2 approach for stage 3 reports decent continuity rates, but very high complication reoperation rates, poor dental implant outcomes, and is expensive, offering no cost benefit over the MARC's protocol.
Now, a completely different approach comes from Dr. Sylvie Delanian, a radiation oncologist who advocates the fibrotrophic model. She's published on a pharmacologic treatment for LRTI, including ORN.
A drug cocktail.
Yes. She completed a phase 2 trial with 54 ORN patients using a daily regimen of pentoxifylline vitamin E and the bisphosphonate clodronate, plus prednisone and ciprofloxacin on weekends. 13 patients had reportedly failed prior HBO2. Details unspecified.
And the results?
Patients were treated for a median of 16 months. Dr. Delanian reported complete response in all patients in a median time of 9 months.
That sounds incredible. Are there caveats?
Several, according to the source. First, staging. 2/3 were called stage 3 by the Epstein scale, involving fistula, fracture, or osteitis. The source questions the term osteitis, as all ORN involves bone inflammation, suggesting potential overstaging. Second, lesion size. Nearly half the patients had exposed bone equals 1 centimeter, a size that can resolve spontaneously or with conservative care. The average lesion size was small, sum of length plus width equals 17 millimeter. Third, definition of success. Complete resolution wasn't required. Healing was defined as exposed bone equals 0.5 millimeters. Fourth, interventions. 36 patients required iterative sequestrectomies, removal of small dead bone pieces. Fifth, outcomes. 15 patients stopped therapy early, and critically 6 patients, 11%, died of sepsis attributed to local infection, fistula, or fracture, progressing to cellulitis sepsis.
11% mortality. That seems extremely high for ORN treatment.
The source notes they know of no other ORN treatment publications reporting such a high mortality rate. They state these results absolutely need confirmation in a randomized trial. Dr. Delanian suggests her drug combo might apply broadly to LRTI, but advocates RCTs.
So Delanian's pharmacologic approach reported 100% response in a phase 2 trial, but faces significant questions about staging, lesion size, definition of success, need for surgery, dropouts, and an alarming 11% mortality rate from sepsis. Needs RCT confirmation.
Finally, the large Hamson et al. Series from Virginia Mason prospectively followed 411 LRTI patients. Among these were 62 with mandibular necrosis.
What were their outcomes?
Of the 43 available for analysis, 73% showed resolution, 21% reported 50-90% improvement, and 5% were unchanged.
So another large series showing good outcomes with HBO2.
Summarizing these divergent opinions, recent papers express conflicting views. Some advocate free flaps without HBO2 for stage 3 RN, arguing for single surgery and patient impatience.
But the source counters that.
Yes, noting patients with chronic RN are often dealing with it for months already and may not be overly impatient of seeing progress. It also highlights the high cost, ICU hospital stays, high reoperation rates up to 60%, and significant donor site morbidity, prolonged wound care, potential skin grafting. associated with free flaps, questioning the overall benefit compared to protocols, including HBO2.
Okay, so synthesizing all this evidence on expressed ORN.
Looking at the total body of literature reported in the source, the single negative RCT, AN, had significant flaws. Positive reports, mainly case series, but including Marx's massive series with 100% resolution and Freiberger's with 86% durable outcome, represent far more patients. Marx alone has 914 than the negative or alternative therapy studies. Gal had 22, and Anne had 31 in HBO2 arm. Delanian had 54, Free Flap series had 21, 89, 79 respectively. Marx's success criteria are also very comprehensive, including functional cosmetic rehab. The source concludes that despite confusing results, the overall weight of evidence, considering cost, safety, and effectiveness, still supports HBO2 use, ideally within a multidisciplinary team, including skilled reconstructive surgeons who perform necessary debridement.
Right. So mega recap for expressed ORN, it's understood as hypovascular hypoxic. The Marx staging system and multidisciplinary approach, HBO2 mostly pre-op plus surgery, is a cornerstone with excellent reported success. Alternative protocols, pharmacologic free flaps without HBO2 purport differing, often less favorable outcomes or have methodological concerns. Despite conflict, the source concludes the overall evidence, effectiveness, safety, cost, supports integrated HBO2 use with skilled surgery, cost impact of HBO2 for ORN.
Now, about the cost. HBO2 isn't cheap, and facilities aren't everywhere, but Dr. Marx did analyze the total costs of managing mandibular ORN.
And what did he find? Is using HBO2 actually more expensive overall?
Quite the opposite, according to his analysis. His estimate in 2016 US dollars showed the total cost to treat ORN without HBO2 was approximately $224,000.
And with appropriate prompt HBO2 combined with surgery.
That cost dropped significantly to about $96,000.
Wow, that's a saving of $128,000 per patient. $224K, $96K.
Exactly. By avoiding more complex surgeries, prolonged hospitalizations, and complications, the integrated approach ends up being considerably cheaper. And the source anticipates similar cost advantages for treating radiation injuries in other tissues.
So, key takeaway on cost. While HBO2 has a price tag, using it appropriately within a combined surgical protocol for ORN is significantly less expensive overall, $128K less per patient in 2016 than managing without it, due to preventing more complex, costly interventions. HBO2 for perimandibular soft tissue radiation injury or neoadjuvant HBO2 prior to dental extractions.
We've established extractions are a major trigger for ORN in heavily irradiated jaws, generally a 6,000 CG. About half of ORN cases follow extractions or other surgery like implants. The rest are spontaneous.
And Dr. Marx directly tested preventing this with HBO2?
Yes, in a landmark prospective randomized trial. He took patients who had received at least 6,800 centigrade to the mandible and needed extractions. They were randomized to either pre-extraction HBO2 or just penicillin prophylaxis.
What was the HBO2 protocol?
The standard prophylactic protocol. 20 daily HBO2 treatments before the extractions, plus 10 additional treatments after.
And the results were striking, weren't they?
Extremely. 37 patients in each group. In the penicillin-only group, almost 30%, 29.9% developed ORN. In the HBO2 group, only 5.4%.
A huge difference. Was the severity different too?
Yes. In the penicillin group, nearly 3/4 of those who got ORN, 8 out of 11, needed stage 3 treatment with segmental resection. In the HBO2 group, the 2 patients who developed ORN both resolved with just stage 1 treatment. No resections needed.
That's incredibly strong level 1 evidence for prophylactic HBO2 in this high-risk setting, reduces incidence dramatically, and reduces severity if it does occur.
So the key principles Marx advocates for prevention, same as for treatment, include that emphasis on pre-surgical pie extraction HBO2 to improve tissue tolerance, including the vital surrounding soft tissues.
And extraction technique itself matters too.
Very much. The source recommends careful technique, surgically closing the sockets, performing an alveoloplasty to smooth any sharp bone edges, and importantly, avoiding unnecessary elevation of the mucoperiosteum if possible.
Have others replicated this success with the Marx protocol?
Yes, several series are mentioned. Lambert et al. Reported no ORN in 47 patients treated prophylactically at a VA center. Vudiniabla et al. And David et al. Reported very low ORN rates, 0.29 and 124 respectively, following the protocol. Chavez and Atkinson reported 98.5% uncomplicated healing in 40 patients. A 2010 review by Hampson found 92% had no resulting ORN out of 166 evaluable patients treated prophylactically.
And Marx's own long-term data.
His latest update, covering over 30 years using the 2010 protocol in high-risk patients, is astounding. A 0.75% incidence of ORN in 936 patients involving over 2,000 tooth extractions.
Okay, so consistent success across multiple series, including Marx's huge long-term experience, confirms the effectiveness of the 2010 prophylactic HBO2 protocol, plus careful surgery in preventing ORA and after extractions in high-risk patients.
Now, the source addresses studies claiming low ORN rates without HBO2.
Like the Salaman paper from Sloan Kettering.
Exactly. They reported only 2.2% ORN in 180 patients with only 3 receiving HBO2, attributing it to atraumatic technique. But the source points out major flaws. Half the teeth extracted were outside the radiation field. 68% received doses lower than Marx's high-risk threshold, many below 6,000 cg. 20% were anterior teeth, often outside the field.
So they were comparing apples and oranges, really, including many low-risk situations.
Precisely. The source argues this is true for all the papers reporting low ORN incidence without HBO2. They consistently include significant numbers of low-risk patients. Lower doses, maxillary teeth, anterior mandibular teeth outside the field. Examples include Makinen et al. 1977 median dose 4,100 cg. Many lymphomas, anterior teeth. Maximu et al. 1991 median dose 5,000 cg. Many teeth outside field or maxillary. And Lai et al. 2007, 41% maxillary, 23% anterior mandibular.
So these studies don't really challenge the need for HBO2 in genuinely high-risk extractions.
That's the source's strong conclusion. Reviews based on these flawed studies, like those by Clayman 1997 and Wall 2006, concluded against mandatory prophylactic HBO2. But the source attributes this to their reliance on data skewed by low-risk patients.
Okay, that context is crucial.
Finally, a recent multicenter RCT by Shaw et al. Tried to update Marx's original prophylactic study.
How did that go?
It struggled significantly. Accrual was very slow, only reaching 50% of the planned enrollment, making it underpowered. To boost numbers, they included patients having dental implants after radiation, not just extractions.
Are implants comparable to extractions in terms of trauma?
Not really. Implant placement typically involves precise drilling with cooling, much less traumatic than the pulling and force often needed for extractions. Also, the Shaw trial allowed patients with doses as low as 5,000 centigrade, whereas Marx's trial focused on high-risk patients receiving 6,800 centigrade or more.
So, the Shaw trial, aiming to replicate Marx, faced issues with power, included less traumatic procedures, and had lower radiation dose criteria, making its results potentially less relevant to the specific high-risk extraction scenario addressed by Marx.
Synthesizing all this on prophylaxis, the source concludes you must look carefully at patient risk. When genuinely high-risk patients are studied, high-dose to mandible, teeth in field, the literature strongly supports prophylactic HBO2 2010 protocol to reduce ORN incidence. Low-risk patients likely don't benefit.
And identifying that risk is key.
Yes. Ideally, review the radiation records, discuss with the radiation oncologist if possible, given the complexity of modern IMRT plans, though admittedly that's not always practical due to patient mobility or time elapsed since treatment.
Mega recap for prophylactic HBO2. Compelling evidence. Mark's RCT multiple series long-term data shows the 2010 HBO2 protocol drastically reduces ORN incidence after extractions in high-risk patients. Studies reporting low rates without HBO2 are criticized for, including mostly low-risk patients. A recent RCT attempting replication faced significant limitations. Bottom line, identify high-risk patients, dose, location, and consider prophylactic HBO2, laryngeal necrosis, and other soft tissue necroses of the head and neck.
Moving to the larynx, laryngeal necrosis is thankfully uncommon after radiation for head and neck cancer. Incidence should be less than 1% with proper technique.
But when it does happen,
it's serious. If you see persistent edema, fetid breath, or visible necrosis more than 6 months after radiation, the standard recommendation has been laryngectomy.
Why so drastic?
2 reasons. High suspicion of persistent or recurrent tumor in that setting, and historically a lack of effective therapies to reverse the necrosis itself. Biopsy is necessary to rule out cancer, but it's tricky risk of sampling error if cancer is submucosal, and aggressive biopsy can worsen the already injured tissue.
There's a staging system.
Yes, the Chandler system grades severity. Grades 1 and 2 might resolve with conservative care, but grades 3 or 4 are very likely to require laryngectomy historically.
But HBO2 offers an alternative.
Evidence suggests it does. 5 institutions published case series applying HBO2, mostly to severe cases, Chandler grade 3 or 4. Across 44 reported cases, only 6 ultimately required laryngectomy. The other 38 preserved their voice box, most with good voice quality eventually.
That's a significant difference from the historical expectation.
And the more recent large Virginia Mason series by Hampson et al. Provides more data. They had 27 patients treated for laryngeal necrosis.
What were their outcomes?
82% showed at least 50% improvement. 20 patients were retrospectively graded by Chandler's system. 18 were advanced grade 3 or 4. All but one of these improved by at least one Chandler grade, and 11 improved by 2 or more grades. Only 2 potentially progressed to laryngectomy. A separate case report showed complete resolution of grade 4 necrosis after 40 HbO2 treatments.
So, strong indication that even for severe laryngeal necrosis, grade 34, where laryngectomy was often the only option, HbO2 can lead to significant improvement, voice box preservation, and functional recovery in a majority of patients.
HbO2 is also used for other head and neck soft tissue problems beyond the larynx, things like necrosis of the neck skin or feeling surgical flaps in irradiated areas.
Dr. Marks has experience here too.
Extensive experience reported in the Whelan and Kinwall textbook. He conducted a controlled, randomized trial involving 240 patients who needed flaps, pedicled or free, to repair soft tissue damage in irradiated fields. He compared wound complications in a group receiving the 2010 HbO2 protocol versus a control group.
And the results.
Statistically, significant reductions across the board with HbO2. Wound infection dropped from 37% to 11%. Dehiscence, wound opening, dropped from 26% to 6%. Delayed wound healing dropped from 46% to 14%. All highly significant, p 0.005.
Powerful results. Others found similar benefits.
Yes. Davis reported success in 15 out of 16 patients, with often extensive soft tissue necrosis of the head and neck. Neovius compared 15 patients treated with HbO2 for post-op wound complications in irradiated fields to 15 matched historical controls.
What was the difference?
In the HbO2 group, 12 healed completely, 2 improved, only 1 failed. In the control group without HbO2, only 7 out of 15 healed. Critically, 2 patients in the control group had life-threatening hemorrhage from erosion into major vessels. 1 died. No serious bleeds occurred in the HbO2 group.
That highlights a potentially life-saving aspect of improving tissue health with HbO2 in these fragile areas.
And one more piece of evidence. Feldmeyer reported, in abstract form, on using immediate post-operative HbO2 after radical salvage surgery for recurrent head and neck cancer in previously irradiated fields.
That's a notoriously high-risk surgery, right? Complication rates over 60%, even fatalities reported without support.
Exactly. But with a short course of post-op HbO2, median 12 treatments, 87.5% of their patients healed surgical wounds without serious complications, and no immediate post-op deaths occurred in that group.
Okay, mega recap for laryngeal and other head-neck soft tissue necrosis. Laryngeal necrosis, especially severe grades, often required laryngectomy, but HbO2 shows significant promise for voice box preservation and improving outcomes based on case series. For general H&N soft tissue injuries and surgical complications like flaps in radiated fields, strong evidence from an RCT and controlled studies shows HbO2 markedly reduces wound infections, dehiscence, delayed healing, and potentially catastrophic hemorrhage. Adjuvant post-op HbO2 dramatically improves outcomes after high-risk salvage surgery. Miscellaneous soft tissue injuries of head and neck cancer patients. A potential as preventive treatment and treatment to enhance quality of life. QOL.
With improving head and neck cancer cure rates, around 2/3, attention is rightly turning to long-term quality of life. An interesting potential role for HbO2 is ameliorating those late radiation effects to improve QL.
Like dry mouth, xerostomia, that's a huge QL issue.
It really is. IMRT helps by sparing salivary glands, reducing the incidence, but it hasn't eliminated it. Radiation damages both the quantity and quality of saliva. It becomes thick, acidic, increasing dental decay risk.
Are there reports on HbO2 helping with this?
A few. Anecdotally, some patients treated for ORNN reported improved saliva. The first formal study, Fontanesi 1991, looked prospectively at 11 patients. 10 of 11 were able to stop using salivary supplements after HbO2. Objectively, 5 of 11 had substantial increases in salivary flow rates.
And a review paper looked at this too.
Yes, Fox et al. Reviewed 7 publications, 246 patients total, mostly receiving 30 HbO2 treatments, often years after radiation. They found, generally, improvements in subjective symptoms, less dry mouth sensation, less sticky saliva, and objective measures, increased stimulated saliva output, with trends towards better QOL scores related to dry mouth. Importantly, most patients were enrolled long after radiation, median 23 months, suggesting spontaneous recovery was unlikely.
So, evidence suggests HbO2 might improve xerostomia symptoms both subjectively and objectively, even long after radiation.
Another small randomized trial by Tegu looked at giving HbO2 immediately after radiation. 19 patients. The study group got 30 HbO2 treatments right away.
What did they find?
Compared to controls, the HbO2 group had improved outcomes on a QL questionnaire, specifically relating to swallowing, saliva quality quantity, and decreased oral pain.
So potentially benefits both long-term and immediate post-radiation QOL issues.
These reports are definitely promising and warrant more investigation. As cancer treatments improve survival, QOL becomes paramount.
Could we target patients for this, like those predictors we discussed earlier?
That's the hope. If we could identify patients at high risk for severe QOL impairment, maybe based on biomarkers or clinical factors like reirradiation, perhaps we could offer prophylactic or early intervention with HBO2. Offering it to everyone probably isn't feasible or cost-effective, and not everyone would want more treatment after aggressive cancer therapy.
But for a high-risk subset, it might significantly improve their long-term comfort and enjoyment of life.
That's the potential.
Mm-hmm.
But again, this needs more high-quality clinical research, including looking carefully at the costs involved.
Mega recap for QOL preventive HBO2. Improving QOL after H&N radiation is crucial. Small studies suggest HBO2 can improve xerostomia symptoms, subjective, objective, and other factors like swallowing and pain, both long after radiation and potentially when given immediately post-treatment. While universal use isn't practical, targeting high-risk patients for QOL improvement is a promising area needing further research and COTS analysis, chest wall necrosis, and other breast cancer LRTI.
Okay, moving to the chest. Radiation after lumpectomy for early breast cancer is standard, and while fat necrosis can happen, it's uncommon. More relevant here is radiation after mastectomy for more advanced disease.
Why is that higher risk?
Because standard technique often involves intentionally giving a full dose to the skin to prevent recurrence in dermal lymphatics. This commonly causes brisk acute reactions, inflammation, severe dermatitis, peeling, sometimes ulceration, and pain.
And this can progress to frank necrosis.
It's fairly uncommon, but when it does occur, frank necrosis of the chest wall is very difficult to manage. Traditional treatment requires extensive surgical debridement, often needing large flaps brought in from outside the radiated field, like omentum or myocutaneous flaps, to provide a healthy blood supply.
Figure 7 in the source shows a case of this.
Yes, Figure 7 graphically illustrates a patient with severe chest wall necrosis involving both soft tissue and bone before HBO2, 7A, showing near complete response after 20 treatments, 7B, durable resolution after 39 treatments, 7C, and even a 15-year follow-up showing continued resolution, 7D. It's a powerful visual of potential long-term success.
When was HBO2 first used here?
Reports go back to 1976, Hart and Manus, showing success using HBO2 as an adjunct to skin grafting for chest wall necrosis.
And later studies.
Feldmeyer et al., 1995, reported on both soft tissue and bony necrosis of the chest wall. Soft tissue necrosis resolves successfully with HBO2 in all cancer-free patients. However, for those with osteoradionecrosis of ribs or sternum, only 8 out of 15 achieved resolution.
What was the difference in the failures?
The common factor was failure to surgically eliminate all the necrotic bone. This reinforces the principle learned from mandibular ORAN. Complete surgical debridement of dead bone is crucial, ideally combined with HBO2 using a similar pre-post-op protocol, like 20 before, 10 after.
So, early reports show HBO2 helps skin grafting. Later series confirm success for soft tissue necrosis, but for bone, surgical removal is key combined with HBO2. Figure 7 shows potential for long-term healing.
HBO2 is also studied for complications after breast-conserving therapy, lumpectomy plus radiation, not just necrosis after mastectomy. Carl and Hartman, 1998, reported a single case of long-standing painful breast edema resolving completely after 15 HBO2 treatments.
And a larger study from that group.
Yes, Carl et al., 2001, studied 44 women with complications like pain, edema, fibrosis, telangiectasias after lumpectomy radiation using a modified Lensoma score to grade severity. They only included patients with severe pain or high overall scores.
How do they study it?
32 women agreed to HBO2, 12 treatments, while 12 refused and formed a control group. HBO2 resulted in a statistically significant reduction in the overall somnolent scores compared to controls. Specifically, pain and edema improved significantly. Fibrosis and telangiectasias did not improve in this study.
What happened to the controls?
Their symptoms didn't improve. In the HBO2 group, 7 women had complete resolution of symptoms.
So for post-lumpectomy radiation symptoms, HBO2 significantly reduced overall symptom burden, especially pain and edema, compared to no treatment, though not fibrocystal angiectasias in this particular study.
Another group, Tego and Associates, prospectively followed 57 women with late symptoms after breast conservation. They reported significant reductions across many symptoms after HBO2.
Such as?
Severe arm-shoulder pain dropped from 46% to 17%, swollen arm hand from 14% to 7%, difficulty lifting arm from 45% to 22%, breast pain from 67% to 15%, breast swelling from 45% to 13%, breast hypersensitivity from 54% to 15%, abnormal skin changes from 32% to 11%. Symptoms were reduced by about two-thirds in most categories.
Wow, very consistent reductions across the board.
And yet another series by Sprout and Vandenberg looked at 67 women with various breast LRTIs, using the Somolent scale again. They received an average of 44 HBO2 treatments.
Their results.
85% had measurable improvement. Median pain and fibrosis grades improved significantly, and this was stable at 12 months follow-up. Breast edema score and median shoulder abduction also improved significantly.
So multiple series now showing benefit for these less severe but still impactful late effects. Is there higher level evidence coming?
Yes, the source mentions a randomized controlled trial called the Honey trial is underway in Holland, specifically designed to provide level 1 evidence on HBO2's impact on pain, fibrosis, impaired arm mobility, and cosmetic outcomes for women with breast cancer LRTI.
Okay, mega recap for chest wall breast cancer LRTI. Chest wall necrosis, often post-mastectomy, is tough, needs surgery. HBO2 plus surgical debridement, especially for bone, shows promise. Figure 7 example. For post-lumpectomy symptoms, pain, edema, fibrosis, limited motion, multiple series, and a controlled study using lymphoma show HBO2 significantly reduces symptoms and improves function, often durably. A level 1 RCT, Honey trial, is ongoing to confirm these benefits. Radiation, cystitis. All right, let's move to the pelvis. Radiation there for cancers like rectal, gynecologic, bladder, prostate often hits nearby organs. Radiation cystitis inflammation of the bladder isn't super common, but when it happens, it can be very difficult to manage.
Extremely difficult. In the most severe cases, it can lead to needing the bladder removed entirely, a cystectomy, with urinary diversion. Conservative measures like instilling formalin or LM as chemical cautery agents are tried first.
How effective is HBO2 for this?
The 2002 Feldmeyer and Hampson review looked at 17 papers, mostly case series, one prospective non-randomized trial by Bevers et al. Many patients in these series had already failed conservative measures. Combining all 145 patients, the resolution rate with HBO2 was 76.3%.
So pretty good results, especially in a refractory population.
Since then, more reports. A small Israeli case series, Naaman et al., 7 patients, 30 TX at 2.0 ATA, reported 100% initial resolution of hematuria, red in urine. 2 recurred but responded again to repeat HBO2.
What about larger series?
The Virginia Mason Group has published extensively. Their early series, Corman 2003, updated by Chong 2005, 57 patients, AFG33TX at 2.36 ATA, reported 80% complete or partial resolution. Chong's update made a crucial point. Outcomes were significantly better if HBO2 started within 6 months of hematuria onset.
How much better?
Improvement rate jumped from 80% to 96% with early intervention. Improvement in clot retention was 100% in the early group. This argues against delaying HBO2 while trying prolonged conservative measures. Their outcomes were also assessed at least 12 months post-HBO2, indicating durability. Their later update, Hampson 2010 review, 44 evaluable cystitis patients, AVG42PX, showed 57% complete response and another 32% with 50-90% improvement. So consistent positive findings from that center.
A more recent review, Cardinal 2018, 16 papers, 602 patients, found an overall 84% partial or complete response rate to HBO2 for radiation cystitis. Recurrence was reported in 14% of cases with 12-month follow-up, happening at a median of 10 months.
So high initial response, but some recurrence risk.
And now we have level 1 evidence. A multi-center phase 2-3 randomized controlled trial by Oscarson and colleagues compared HBO2 30-40 sessions at 2.4, 2.5 ATA to standard care.
What did they measure?
They used the Expanded Prostate Index Composite Score, or EPIC score, a validated tool to quantify severity and response. The primary outcome was the change in the self-reported score.
The result?
A statistically significant improvement in the EPIC score for the hyperbaric group compared to the control group, 10.1-point change versus 7.7. Clear benefit shown in an RCT.
That's really important evidence. And to underscore the seriousness of hemorrhagic cystitis specifically, the source mentions a series by Chang and Fu treating 9 refractory cases without HBO2. Despite aggressive surgery, nephrostomies, cystectomies, 44% of those patients died as a result of their cystitis. Another review reported a 3.7% mortality rate in 378 patients with hemorrhagic cystitis after cervical cancer radiation.
Wow, that really puts the HBO2 results in perspective.
It does. In summary for cystitis, The vast majority of published series and now a positive RCT show HBO2 is effective, 76 and 84% response rates, especially if started early, 6 months. This contrasts sharply with reports of poor outcomes and significant mortality in refractory cases treated without HBO2, even with radical surgery. While 40 treatments is typical, some may need 60 plus Phi, and retreatment for recurrence is often successful. Cystoscopy might help guide duration.
Mega recap for radiation cystitis, a difficult, potentially life-threatening complication. Overwhelming evidence, multiple series, level 1 RCT, supports HBO2 effectiveness, high response rates, particularly with early intervention, 6 months. Contrast this with poor outcomes mortality without HBO2. Extended courses or retreatment may benefit some. Radiation proctitis and enteritis.
Moving on to the bowel. Radiation enteritis, small bowel, and proctitis rectum are often discussed together. There's a bit of a paradox here.
What's that?
The small intestine is known to be more sensitive to radiation damage and lower doses. Yet clinically, the colon and especially the rectum are injured more frequently.
Why is that with modern techniques?
Because modern targeted radiation is much better at avoiding the mobile small bowel. The large bowel, particularly the rectum, is often fixed in position retroperitoneally and is usually much closer to pelvic tumor targets, prostate, cervix, uterus, rectum itself. So it more commonly receives a potentially damaging dose despite precise techniques.
Makes sense. Less wiggle room to spare the rectum.
There's animal study evidence here too. Feldmeyer and Associates showed prophylactic HBO2, given 7 weeks after radiation exposure, was highly successful in preventing radiation-induced enteritis in experimental animals compared to controls.
How do they measure that?
They looked at gross pathology and microscopic changes, histologic morphometry, finding statistically significant reductions in signs of enteritis. They also did mechanical stretch tests and quantitative histology, showing significant reduction in submucosal fibrosis and increased compliance, less stiffness, in the HBO2-treated animals.
So animal data strongly supports a preventative role for HBO2 in radiation bowel injury, including reducing fibrosis.
Clinically, for established proctitis enteritis, the 2002 Feldmeyer and Hampson review identified 9 papers, 114 total cases. The results showed 36% had complete resolution and another 60% had symptom improvement. Only 4% had no benefit.
So high rates of at least some improvement.
Since then, more reports. A case report, NEURATH, documented successful resolution of severe malabsorption from radiation enteritis after 20 HBO2 treatments at 3.0 ATA. Jones et al. Reported on 10 patients with proctitis, some severe, needing transfusion. Rectal bleeding resolved or improves in 7-10. Rectal pain resolved in 55 affected. Diarrhea improved in 45 affected. Outcomes were durable at 25 months follow-up.
Another series from Cincinnati, Gurnias et al., looked at 9 patients with hemorrhagic proctitis, many refractory to other treatments.
Yes, with HBO2, they reported complete resolution in 7 of the 9 and significant improvement in the other 2, with durable results at 17 months median follow-up.
The Virginia Mason group published on this too.
Yes, 2 papers. They're first reported on 65 patients, rectal or more proximal GI injuries. They used an initial 30 HBO2 treatments at 2.36 ATA, with more given if only partial response. Overall, complete response was 43%, partial response 25%. Results were slightly worse for rectal lesions compared to more proximal bowel.
So consistent findings of benefit across several series, often in refractory cases.
Now, really strong evidence comes from a randomized controlled double-blinded trial by Clark et al., sponsored by the Baramedical Research Foundation, specifically for refractory chronic radiation proctitis.
How is it designed?
150 patients enrolled, 120 evaluable, assessed using standard Somolent scoring. The active arm got HBO2 at 2.0 ATA. The sham arm breathed air at slightly elevated pressure, 1.1 ATA, to maintain blinding. After 30 treatments, the blinded physicians could give 10 more if partial response. Controls could cross over later.
And the outcome.
With an average 2-year follow-up, the HBO2 group showed statistically significantly greater improvement in Somolent scores, 5.00 versus 2.61, p to 0.00019. Responders were 88.9% in the active arm versus 62.5% in controls, p 0.000009. The number needed to treat was only 3. Really impressive results from a rigorous trial.
That's level 1 evidence confirming HBO2 efficacy for refractory proctitis.
An updated report from the Virginia Mason Group in their 2010 General Review on enteritis proctitis showed 25% resolution, 38% improved, 50-90%, 25% improved, 50%, 12% unchanged. Likely some overlap with their earlier report.
Was there a negative trial as well?
Yes. Glover and co-investigators reported a negative RCT in 2015, 84 patients randomized. They used 40 HBO2 treatments at 2.4 ATA, Their endpoints were change in inflammatory bowel disease questionnaire, IBDQ score, and rectal bleeding score.
And they found no difference.
No significant changes detected in either measure at 2 weeks or 12 months post-treatment compared to sham controls.
But this trial faced criticism.
Several points were raised, potentially including patients with minimal symptoms, using the IBDQ, which is designed for inflammatory bowel disease, not radiation injury, and the very long duration of proctitis before patients entered the trial, median 43 months, suggesting potentially fixed, irreversible damage.
So methodological concerns might explain the negative result.
Finally, and very significantly, the American Society of Colon and Rectal Surgeons, ASCRS, published clinical practice guidelines for chronic radiation proctitis in 2018.
What did they conclude about HBO2?
After reviewing various treatments, they determined HBO2 is a Class 1B indication. That means it's strongly indicated based on moderate quality evidence.
Coming from a surgical society, that's high praise, isn't it? Since they often have to manage the refractory cases surgically.
Exactly. Recalcitrant radiation proctitis often requires major surgery in tissues that heal poorly due to radiation. So their strong recommendation for HBO2 is quite telling.
Mega recap for radiation proctitis enteritis. Rectal injury, more common than small bowel due to anatomy targeting. Animal data shows prophylactic HBO2 prevents enteritis fibrosis. Clinical evidence for established disease is strong. Multiple series show high response rates, 60 to 96%. A rigorous level 1 RCT, Clark confirmed significant benefit. A negative RCT, Glover, had methodological flaws. Crucially, the ASCRS strongly recommends HBO2, Class 1B indication, for chronic radiation proctitis. Other abdominal and pelvic injuries. What about other pelvic structures besides bladder and bowel, like vaginal necrosis?
Yes, there's evidence there too. Williams out. 1992 reported on 14 patients with vaginal necrosis. 13 had complete resolution with HBO2. 1 needed a second course.
And the broader review by Feldmeyer in 1997.
That reviewed 44 patients with various pelvic abdominal injuries treated with HBO2 at 2.4 ATA. 41 were evaluable. They found success in necrotic groin wounds. 44 healed, pelvic bone necrosis, 11 healed with adequate TX, perineal wounds, 34 healed with adequate TX, and vaginal necrosis, 55 healed.
What about fistulas? Those are notoriously difficult.
Yes, a key finding was in a subset of 8 patients with rectovaginal or rectovesical fistulae. 6 of the 8 resolved with HBO2, and remarkably, 3 of those resolved without needing surgical intervention. This is significant because surgical closure of these fistulae after radiation is very challenging with high failure rates, often requiring major flap reconstructions.
So HBO2 might obviate complex surgery in some fistula cases.
A more recent series by Fink et al. Looked at 14 patients with various pelvic injuries, including 6 with vaginal issues. Ulcers, stenosis, vaginitis. Many had multiple organs involved. For the vaginal injury patients, results were mixed but generally positive. 1 complete resolution, 4 with 50% response, 1 with 50% improvement. Overall, for the entire pelvic injury group, mostly 30 TX at 2.4 ATA, 71% had greater than 50% improvement.
And a Canadian review looked specifically at gynecologic radiation injuries.
Yes, Craighead et al. Reviewed literature, RCTs, and non-randomized trials on HBO2 for LRTI after pelvic radiation for GYN cancers. This included cystitis, proctitis, enteritis, bone necrosis, QL issues.
Their conclusions.
They concluded HBO2 was effective for delayed radiation injury, especially for anal and rectal injuries. They also found limited but consistent evidence that HBO2 is useful in reducing complications when surgery is needed within the radiated pelvic field to address necrosis.
Mega recap for other abdominal pelvic injuries. Evidence supports HBO2 for various pelvic LRTI, including high resolution for vaginal necrosis. Notably, strong findings for rectovaginal vesical fistulae, with resolution reported in most cases, some avoiding surgery altogether very significant given surgical difficulty. A major review confirms efficacy, especially for anal rectal injury, and utility in reducing surgical complications in radiated pelvic fields. Miscellaneous cutaneous radiation injuries? Radiation-induced skin necrosis?
Radiation can also cause skin necrosis, often seen on lower extremities, abdominal wall, chest, head, neck, etc. Early literature was sparse. A 1978 report was negative.
But a later series showed benefit.
Yes, Feldmeyer et al. 2000 reported on 17 patients, mostly with lower extremity skin necrosis, some lesions quite large, 10 centimeters. 11 of 17 had complete resolution. If you exclude those lost to follow-up or with recurrent cancer, 11 of 13, 85% resolved.
What about abdominal wall skin?
The Virginia Mason Review included 15 cases of anterior abdominal wall skin necrosis treated with adjuvant HBO2. 8 healed completely. 4 did not heal, and 3 had received Inadequate HbO2, fewer than 20 treatments, suggesting dose matters.
So minimum number of treatments seems important for success.
It appears so. A 2016 systematic review by Borab looked at 8 publications, 720 patients total, on HbO2 for radiation skin necrosis across various sites. They noted limitations in the data, like lack of radiation dose details. One senior author reported routinely using HbO2 for difficult cases, large FIs over implants.
Their conclusion.
They concluded HbO2 is safe and promising for skin necrosis, but recommended a prospective RCT for level 1 evidence.
And findings from other sites are relevant here too.
Yes, the source points out that discussions about chest wall, breast, and head neck injuries where skin is heavily involved also support HbO2 use for skin damage, including necrosis and ulceration anywhere on the body. Figure 8 provides a visual example. Photos show HbO2 facilitating successful skin grafting over a large radiation necrosis defect on a forearm with durable 15-year follow-up.
Mega recap for cutaneous injuries. Radiation skin necrosis can be extensive. Series and reviews suggest HbO2 is safe and promising, improving healing, up to 85% resolution in one subset, and aiding skin grafting, figure 8 example. Success seems linked to adequate treatment, 20 sessions. Evidence supports use across sites, though level 1 RCT evidence is needed. Neurologic injuries secondary to radiation.
Okay, neurologic injuries. This is a particularly challenging area. The 2002 review identified 14 publications reporting HbO2 use for various neurologic LRTI. Spinal cord injury, myelitis, brain necrosis, optic nerve injury, and nerve plexus damage, brachial or sacral plexopathy. Evidence is often limited.
Let's start with radiation myelitis. Radiation myelitis.
Radiation myelitis is, thankfully, very rare, incidence around 0.2% in 1HN series, but devastating. If fully expressed, it's like a functional cord transection, causing paralysis and sensory loss. Prognosis is poor, with high mortality, 2/3 dying within 4 years. No other known curative treatments exist.
What does the HbO2 evidence show?
It's mixed and limited. Hart, 1976, reported no motor improvement in 5 cases. Glassburn, 1977, reported improvement, including some motor function, in 6 of 9 cases. Calabro, 2000, reported 1 case with both clinical and MRI improvement.
Animal studies.
Also complex. Feldmeyer found delayed onset but no permanent prevention with prophylactic HbO2 in 1 model. Sminia suggested potential radiosensitization if HbO2 is given right after radiation, but no radioprotection in another model.
What about more recent clinical data?
Feldmeyer reported a single case in 2009. A woman with multiple myeloma developed radiation myelitis, Brown-Sequard pattern, after spinal radiation. She received 40 HbO2 treatments at 2.5 ATA.
The outcome.
Substantial improvement in motor sensory deficits, including resolved foot drop, allowing rehab. Importantly, she hadn't suffered complete functional loss initially. Post-HbO2 MRI showed resolution of the cord abnormalities seen pre-treatment. Figure 9 shows these pre-post images. Her improvement was durable at 3-year follow-up.
That's a very positive outcome in one case.
Yes, but it's just one case. Given the severe consequences of myelitis and lack of other options, the source suggests considering HbO2 on a compassionate basis, especially if some neurologic function remains. Prompt initiation is key. As damage can become fixed quickly, they recommend 40 treatments at 2.4 ATA. More study is clearly needed.
Mega recap for radiation myelitis. Rare, devastating, high mortality, no other known cure. HbO2 evidence is mixed limited. Early series inconsistent, animal studies complex. A compelling case report showed durable clinical MRI improvement with 40 TX in a patient with residual function, figure 9. Compassionate use recommended due to severity, lack of alternatives, emphasizing prompt initiation, adequate pressure duration, more research vital, brain necrosis.
Radiation necrosis in the brain is more common than myelitis, but incidence varies widely. 5.25% maybe, pooled average 6.5% after SRS for high-grade gliomas, but up to 44% for recurrent gliomas. Depends heavily on dose, fractionation, volume treated.
And distinguishing it from recurrent tumor is a major challenge.
Huge challenge. Yeah. Standard imaging often can't tell them apart. Metabolic imaging like PT or MRI spectroscopy helps, but has limitations, e.g. PD resolution. Both can coexist.
What are the treatment options besides HbO2?
Few effective ones. Surgical resection is possible if the necrosis is in a non-eloquent brain region and accessible.
Yeah.
Bevacizumab, a VEGF inhibitor, can reduce edema by decreasing vascular permeability, but its impact on functional status is less clear. One study showed edema reduction in 79%, but performance status improvement in only 42%.
So, limited options. What does the HbO2 literature show?
Early reports were positive. Single case improvement. Hard 1976. Initial improvement in 10 children. Chuba 1994. 56 survivors maintained it. Clinical imaging improvement in 2 post-radiosurgery AVM cases. Lieber 1995. Avoided steroids. 1 had complete MRI resolution. 1 case report, Swarovski 1996, showed no clinical improvement in brainstem necrosis, but MRI resolution years later.
More recent findings.
Deer et al. Reported improvement in 9 of 20 patients, though results were poor in glioblastoma patients, likely confounded by tumor progression. The largest series to date, Gaisel et al., 29 patients, found objective neurologic exam improvement in 58% and reduced steroid need in 69%. A review of pediatric cases, Dresner, found HBO2 plus steroids led to clinical response, improvement stabilization resolution, in 92%, comparable to bevacizumab plus steroids. A recent adult series, Coelho, 13 patients, showed clinical improvement in 12, with imaging improvement or stability.
So generally positive signals from case series and reviews showing potential for clinical and sometimes imaging improvement and reduced steroid dependence.
Yes. Given the dire consequences of brain necrosis and limited alternatives, the source recommends considering HBO2 based on compassionate grounds and the reported success rates. 60–70% improvement range suggested. Ideally, this needs confirmation in a large Phase 3 RCT, potentially through cooperative groups.
Mega recap for brain necrosis. Incidence varies. Diagnosis versus tumor difficult. Few effective treatments. Surgery if possible. Bevacizumab for edema. Case series reviews suggest HBO2 offers clinical improvement, 58% objective improvement in largest series, reduced steroid need, some imaging resolution. Compassionate use recommended due to severity lack of alternatives pending large RCTs. Radiation-induced optic neuropathy.
Optic neuropathy from radiation is another devastating complication, potentially causing blindness. Again, evidence for HBO2 is mixed.
What do the positive reports show?
Borowat reported a case of bilateral optic neuritis where HBO2 led to complete resolution in the more recently affected eye and partial resolution in the first profoundity, suggesting early intervention helps. Fontanesi reported substantial vision improvement in a child refractory to steroids after 20 HBO2 treatments at 2.0 ATA. Boschetti reported objective visual field improvement in the better eye in an adult refractory to steroids at 2.2 ATA 41 TX, though the blind eye remained blind.
So some promising case reports, especially with early treatment or steroid failure, but there's a negative series.
Yes, the largest series by Roden et al., 13 patients, reported no improvement in any patient. However, this study was criticized by Guy in a letter.
What were the criticisms?
Delayed treatment. None started HBO2 less than 2 weeks after symptom onset, some up to 12 weeks late. Lower pressure. Roden used 2.0 ATA, whereas Guy, who reported success, used 2.8 ATA. Limited assessment. Roden only reported central visual acuity, not visual field mapping, which might have shown peripheral improvement, like in Boschetti's case.
Okay, so the negative series has potential limitations regarding timing, pressure, and assessment methods.
Another report, Malik and Golnick, described outcomes in 4 patients, some bilateral, treated with steroids, but didn't clearly link HBO2 to outcomes in this snippet. A case report by Lean showed temporary vision recovery after 2 courses of HBO2, 30 plus 40 TX, allowing the patient to walk unassisted, along with MRI resolution of nerve injury signs, but she ultimately relapsed into blindness.
So overall,
Pooling the outcomes mentioned, only 7 patients showed improvement, while 18, including the temporary responder, had permanent progressive loss. 13 non-responders were from the criticized Roden study. A definitive case for routine HBO2 use cannot be made based on this. However, the source argues its application can be supported by the shared mechanisms with other CNS injuries, brain myelitis. Given the dire prognosis, blindness, and lack of other therapies, compassionate use should be considered. The data strongly suggest prompt initiation, ideally 72 hours, and adequate pressure, 2.4 ATA, are crucial for any chance of success.
mega recap for radiation optic neuropathy. Mixed evidence. Some case reports show significant improvement. Visual acuity fields, MRI resolution, especially with early treatment or after steroid failure. Largest series was negative but criticized for delays pressure assessment. Only 725 reported outcomes showed durable improvement. No definitive case for routine use, but compassionate use recommended due to severity lack of alternatives, stressing prompt initiation, 72 H's, and adequate pressure, 2.4 ATA. Brachial plexus and sacroplexus.
Lastly, for neurologic, nerve plexus injuries. Radiation can damage the brachial plexus, affecting the arm, or sacral plexus, affecting leg pelvic function.
Is there evidence for HBO2 here?
Very limited. A single case report, Videtic 1999, described resolution of symptoms and improved ambulation with HBO2 for radiation-induced sacral plexopathy. Patients stopped narcotics.
What about the brachial plexus?
A randomized controlled trial by Pritchard et al.
Yeah.
Looked at HBO2 for radiation brachial plexopathy. Unfortunately, the trial was negative. No statistically significant improvement in the HBO2 group compared to controls.
Were there limitations to that trial?
A major one. The median time from onset of neuropathy to entering the study was 11 years. It's highly likely the nerve damage was fixed and irreversible by that point.
Did they see any effect at all?
Interestingly, while no improvement, the HBO2 group experienced less progressive deterioration than the control group. Also, unexpectedly, 6 patients in the HBO2 group who had lymphedema showed improvement in their arm swelling, which wasn't seen in controls.
So, limited evidence for plexopathy. 1 positive sacral case report, 1 negative brachial RCT likely flawed by extreme delay, though showing less progression and possible lymphedema benefit.
Correct. As with other neurologic injuries, the source suggests considering HBO2 based on severity and lack of alternatives, ideally initiated early with adequate protocol while acknowledging the weak evidence base.
Mega recap for plexopathy. Evidence is scant. 1 positive sacral case, 1 negative brachial RCT likely limited by tenure delay. Consider compassionate use due to severity, lack of alternatives, stressing promptness protocol, more research needed. 3 broad publications of note for radiation necrosis. Okay, besides site-specific studies, the source highlights 3 broad publications that look at HBO2 for LRTI across the board.
Yes, these provide important context. First, a report from the American College of Hyperbaric Medicine's patient registry, reviewing over 2,500 patients treated with HBO2 for various LRTI.
What were the main sites and outcomes?
Most common sites were mandibular ORN, 33%, skin necrosis, 27.5%, radiation cystitis, 18.6%, Proctitis 9.2%, and laryngeal necrosis 4.8%. They reported positive results across the board, with the resolution or improvement rates ranging from 76.7% to 92.6%, depending on the site.
So, large registry data shows high positive outcomes across common LRTI sites.
Second, the report from the 10th European Consensus Conference on Hyperbaric Medicine, held in 2016. This involved 44 experts from multiple countries using formal methods, grade system Delphi method, to evaluate evidence and reach consensus.
What were their recommendations?
They gave their strongest recommendation, type 1, strongly recommended, for treating mandibular ORN, radiation cystitis, and radiation proctitis. They gave a level 2 recommendation, recommended for ORN and bones other than the mandible, for using HBO2 to support dental implants in irradiated bone and for most soft tissue injuries, excluding rectum bladder, which were type 1. For laryngeal or CNS injuries, they gave a level 3 recommendation, reasonable to treat, reflecting the weaker evidence base there.
So, a formal expert consensus process ranked indications based on evidence strength, giving highest support to ORN, cystitis, and proctitis.
Third, the Cochrane collaboration updated their review on HBO2 for late radiation injuries in 2016. Cochrane reviews are known for rigorously focusing primarily on randomized controlled trials.
What did they find?
They reviewed 14 trials involving 753 participants. Their main findings were that there was some evidence that HBO2 improved outcomes for LRTI, affecting bone and soft tissues of the head and neck, for radiation proctitis, and for preventing osteoradionecrosis, like before extractions.
How did they rate the quality of that evidence?
Moderate quality, limited by small study sizes, often poor reporting of methods and results, and uncertainty about the exact degree of benefit. They noted the positive Oscarson RCT for cystitis hadn't been published yet, so it wasn't included.
But given Cochrane's very strict criteria,
Yes. The source suggests that getting even this level of positive determination from Cochrane represents substantial support for HBO2 in these areas. The Cochrane review also highlighted the need for studies looking at comparative costs.
mega recap for broad publications, 3 key overviews. 1. A large U.S. registry shows high positive outcomes, 77 and 93% improvement resolution across common LRTI sites. 2. A European Consensus Conference strongly recommends HBO2 for mandibular ORN, cystitis, proctitis, type 1, recommends it for other bone ORN implant soft tissues, level 2, and deems it reasonable for larynx CNS, level 3. 3. A rigorous Cochrane review finds moderate evidence supporting HBO2 for H&N bone soft tissue LRTI, proctitis, and ORN prevention, calling this substantial support despite study limitations and noting the need for cost data. Special considerations. Hyperbaric oxygen for radiation-induced xerostomia, dry mouth. Let's revisit xerostomia briefly as a special consideration. Huge QL impact after head and neck radiation, right?
Massive impact. IRT helps but doesn't eliminate it. Saliva gets thick, acidic, promotes decay.
And HBO2 might help.
A few reports suggest so. Anecdotally, ORN patients reported improvement. Fontanesi's 1991 study found N111 patients stopped salivary supplements, and 511 had objective flow increases after HbO2. A review by Fox et al. Looked at 7 publications, 246 patients, often 2 years post-RAD.
The consensus.
Generally, patients had increased stimulated saliva output, subjective improvement, less dry mouth, sticky saliva, and trends toward better QL scores. Since most were treated long after radiation, spontaneous recovery was unlikely.
So HbO2 appears to offer a potential benefit for xerostomia, improving stimulated flow and subjective symptoms, even years after radiation. Hyperbaric oxygen as a modulator of radiation injury.
Most of the discussion so far has been on treating established LRTI, but there's growing literature on using HbO2 preventatively or as a modulator, especially before surgery in irradiated fields.
Like the ORAN prevention data we covered.
Exactly. Marx's trial was the first clinical report showing prophylactic HbO2 dramatically reduced ORAN after extractions, from 29.9% to 5.4%. This 20 pre-10 post protocol is key.
What about dental implants? Surgeons are often hesitant in irradiated jaws due to high failure rates and ORAN risk.
Right, but Marx and Granstrom reported significant benefit using the same 2010 HbO2 protocol around implant placement. Marx achieved an 84% osseointegration success rate and prevented ORAN in 100% treated this way. Granstrom's 2006 review found a failure rate of only 13.5% with peri-implant HbO2 versus 21.4% without it in radiated jaws. UATA reported 92.3% success.
So strong evidence for preventing ORAN after extractions and improving implant success in irradiated bone using the 2010 HbO2 protocol.
We also discussed Feldmeyer's report on preventing serious wound complications after radical salvage surgery in irradiated head and neck fields. Immediate post-op HbO2 led to 87.5% uncomplicated healing versus 60% complication rates reported without it.
And Pomeroy used preoperative HbO2 for pelvic soft tissue surgery.
Yes, reporting uneventful post-op courses in 5 patients, although some needed a second procedure. Plus, the animal study showing HbO2 prevents radiation enteritis fibrosis.
So a strong case for prevention across different scenarios.
It's a promising area for research, defining who benefits most from prophylactic HbO2. Identifying reliable predictors would help target high-risk patients. For now, a reasonable approach is providing adjunctive HbO2 when major surgery is planned in a heavily irradiated field, given the high complication rates without it.
Should we think of this differently? Not just prevention, but...
The source suggests thinking of it as neoadjuvant therapy. Just like pre-op chemo or radiation aims to optimize the surgical field, neoadjuvant HbO2, given 6 weeks post-radiation, before surgery, aims to improve the irradiated tissue bed's health, vascularity, fibrosis, before the stress of surgical healing.
That makes sense. Improving the soil before planting the seed of surgery.
Exactly. And this preventive neoadjuvant approach is likely more cost-effective than dealing with major complications and reconstructions later. Hopefully, the literature provides practitioners the support needed to make the case for this.
Mega recap for HbO2 as modulator prevention. Strong evidence supports prophylactic neoadjuvant HbO2 before surgery in irradiated fields. It drastically reduces ORAN after extractions, improves dental implant success, and reduces major wound complications after high-risk salvage H&N surgery. It likely improves outcomes for pelvic surgery, too. Think of it as neoadjuvant therapy to optimize the tissue bed before surgical stress, likely saving costs and morbidity compared to treating complications. Identifying high-risk patients is key. Concerns related to potential carcinogenesis or cancer growth enhancement. Okay, a crucial point. The fear that HbO2 might promote cancer growth or recurrence in these patients who've already had cancer. Is this a valid concern based on the evidence?
It's a frequently expressed concern and intuitively understandable since HbO2 promotes cell growth in wounds. However, the overwhelming consensus among hyperbaric physicians, supported by evidence, is that HbO2 does not enhance malignant growth or recurrence.
What's the evidence?
Marx's huge series of 914 ORAN patients showed no increased recurrence rate in those receiving HbO2, compared to controls he followed, 28.5%, 30.8%. Feldmeyer's 2003 review of clinical and preclinical studies found the vast majority showed no enhancement of cancer growth. 2 subsequent comprehensive reviews, Doral 2006, Moe and Stur, reached the same conclusion. No evidence HbO2 stimulates tumor growth or enhances recurrence.
Why wouldn't it, if it promotes healing?
The reviews emphasize that while similar, wound healing angiogenesis and tumor angiogenesis are distinct processes regulated by different growth and inhibition factors. Also, tumors often contain hypoxic cells, which are actually more aggressive, metastatic, and resistant to treatment. Oxygenating these areas doesn't necessarily fuel growth, Some animal studies even showed HBO2 modestly decreased growth or metastasis rates.
More recent animal studies confirm this.
Yes, studies on transplanted prostate cancer, mammary tumors, head neck xenografts, colorectal liver mets all negative for enhanced growth with HBO2. One study on transplanted human mammary tumors actually showed inhibited growth.
So very consistent findings against enhancement. What about the few reports suggesting a link?
The source critiques these. LRTI's anecdotal report of urothelial tumors ignored prolonged catheterization, a known risk factor in the patients. Bradfield's report of rapid progression in 4 H&N patients involved advanced or suboptimally treated cancers already prone to aggressive behavior. Lynn's retrospective study showing higher recurrence in 11 salvage H&N patients who got HBO2 for necrosis faced criticism for small numbers, short follow-up, and unmatched groups. Only the HBO2 group had necrosis, so maybe necrosis itself was the risk factor. Their survival rate wasn't significantly worse than expected for salvage surgery overall.
So these isolated reports don't stand up well against the bulk of the evidence.
That's the conclusion. The overwhelming evidence finds no link. Therefore, the authors state it's not inappropriate to offer palliative HBO2 for radiation injuries or other indications even in patients with active malignancy, often concurrently with systemic therapies.
Mega recap for cancer concerns. Despite intuitive fears, overwhelming evidence, large clinical series, multiple reviews, numerous animal studies, shows HBO2 does not stimulate tumor growth or recurrence. Mechanisms differ from wound healing. Hypoxia promotes aggressive tumors. A few conflicting reports are anecdotal or flawed. It's considered safe to use HBO2 for appropriate indications, even in patients with active malignancy. Utilization review.
Just a practical note on utilization review. The force suggests this should typically be accomplished after 60 treatments for radiation injury management.
And the usual course length.
Generally in the range of 40 to 60 daily treatments, usually at 2.0 to 2.5 atmospheres absolute ATA for 90 to 120 minutes of 100% oxygen per session.
Is there a preferred pressure?
Mark's work and the author's experience suggest 2.4 ATA is preferred. However, 2.0 ATA has also been used successfully. Mark's recommended that if using 2.0 ATA, the duration should be increased to 120 minutes. An abstract comparing 2.0 versus 2.4 ATA for cystitis found comparable eventual results, but the 2.0 ATA group needed, on average, 5 more treatments.
Okay, so utilization review after 60 TX. Standard is 40-60 TX at 2.0, 2.5 APA, 90 to 120 minutes. 2.4 ATA preferred, 2.0 ATA effective, but may need longer, more sessions. Cost impact?
Finally, cost impact again. Serious radiation complications affect 5–10% of the 600,000 patients getting radiation annually in the U.S. That's potentially 6,000 to 30,000 people each year.
And these complications often lead to surgery in air-radiated fields, which carries a high risk of post-op complications, around 50%.
Correct. By either avoiding surgery altogether or supporting surgical healing to prevent those complications, HBO2 therapy can significantly cut costs, both financial and human.
We already heard Marx's ORAN estimate, $224,000 without HBO2 versus $96,000 with optimal HBO2 plus surgery in 2016, $128,000 saving per patient.
And the source expects similar cost advantages applied to treating radiation injuries in other tissues as well.
Mega recap for cost impact. Serious LRTI affects thousands annually, often needing high-risk, costly surgery. HBO2 significantly reduces overall costs, example 128K saving patient for ORAN, by preventing and mitigating complications and avoiding more extensive interventions. Savings likely apply across other LRTI sites. Outro. Well, we have covered an immense amount of detail in this deep dive, from the complex etiology of delayed radiation injuries, really moving beyond just blocked arteries to fibrosis, stem cell issues, to the very specific applications and the sometimes controversial evidence for hyperbaric oxygen across so many sites. Mandible, head, neck, soft tissues, breast, bladder, bowel, pelvis, skin, CNS.
We really have. We've seen strong evidence for HBO2 in preventing ORAN after extractions and improving outcomes in established ORAN, especially within that multidisciplinary surgical approach. We've reviewed promising data for laryngeal necrosis, head and neck wound healing, cystitis, proctitis, skin necrosis, while also acknowledging where the evidence is perhaps less robust, like for CNS injuries, often limited to case series or facing those methodological critiques we discussed.
And we looked beyond just treating established damage, the potential to improve quality of life by reducing things like xerostomia, and that really compelling role for HBO2 as a neoadjuvant therapy before surgery in irradiated fields to prevent complications. The evidence there seems quite strong, and the cost implications potentially huge.
Absolutely. And critically, we addressed the safety concern regarding cancer growth, finding the overwhelming evidence points to HBO2 not stimulating tumor growth or recurrence.
This deep dive really highlights the complexity of late radiation injuries and just how much our understanding is evolving, particularly regarding how hyperbaric oxygen can fit into managing these challenging conditions. While there's significant evidence supporting its use for many indications, especially when integrated properly, challenges clearly remain. Identifying the right patients, standardizing protocols for less common indications, conducting more high-level randomized trials, there's still work to do.
Definitely. So for you, the specialist clinician listing, as you navigate these complex cases, reflecting on everything we've unpacked today, the mechanisms, the staging, the specific study outcomes, the economics, what aspects of managing delayed radiation injuries feel most challenging in your own practice? And perhaps more pointedly, how might the potential of using HBO2, whether prophylactically or targeted, guided by careful patient selection and that crucial multidisciplinary approach, shift how you think about tackling these difficult clinical scenarios going forward?